Well, greetings, everybody. Welcome to another session of the Trauma Geek. Going to present a shorter than normal talk this morning on the shock index. This is a talk that I recently gave at the 2025 annual conference of the Emergency Nurses Association in New Orleans, Louisiana, and it was very favorably received. I've done a similar talk on the shock index. A little over a year and a half, maybe even closer to 2 years ago now, as part of the Trauma Nursing Journal Club. But I really kind of teased this out as just a talk unto its own about the shock index. And I provided this talk in a number of different venues over the last couple of years, and just wanted to get an opportunity to get it up here on the YouTube channel so that everybody can enjoy it. So I do hope you find the talk beneficial. My goal with this talk, as with any, is that it gets you thinking about your practice, and it gets you thinking about, can the information that I'm learning today be helpful to my practice, particularly as it pertains to the care of the trauma patient, but this could be for any patient across the spectrum who could be in shock. And can I use it? Is this something that's useful for me in my practice? And I hope you find that it is. It certainly has been useful for me in my practice, both in the pre-hospital setting as well as in the trauma resuscitation bay. So for those of you that don't know me, and I hope you all do know me since you're on the YouTube channel, my name is Steve, and I am with the Department of Surgery, the Division of Trauma at St. Joseph's University Medical Center in Paterson, New Jersey. We are a New Jersey designated regional trauma center. A level 2 trauma center is verified by the American College of Surgeons. I do a lot of the ongoing trauma education for both hospital-based clinicians and our pre-hospital colleagues. So whether or not you practice in the pre-hospital environment, and I hope some of you watching do, or you practice in the emergency department, I hope you can take a lot out of what I have to offer today. I do have nothing to disclose. And the objectives of the talk are really simple. First of all, we want to define what the shock index is. Some of you watching, and perhaps many of you watching, tuned in because you don't know what the shock index is. And if that's the case, then I definitely hope we eliminate that for you today. For those of you that are using the shock index, maybe you're using this talk as a review, and I appreciate that. But we are going to define the shock index, and we're going to relate the shock index to the care of the trauma patient, obviously. And we're going to discuss a little bit about the history behind the shock index, because this is not something that just came up in the last 4 or 5 or 6 years. This has been around for quite some time. And then we hope I'll give you some information that'll allow you the rationalization to be able to go out and practice the use of the shock index in your clinical environment. So for those of you that are out there, and again, this isn't interactive like it sometimes is live with topics in trauma nursing or the Trauma Nursing Journal Club, but who of you have heard of the shock index? So, I mean, all of you now have heard of the shock index, obviously. You're participating in this talk, and so now you're like, "Huh." So the question is, before you saw this talk, before you saw the title, how many of you had heard of the shock index? And what I typically find is that pre-hospital providers have heard of it because they are well underway at integrating the shock index into their clinical practice, and not always for the trauma patient. A lot of rapid sequence intervention, RSI protocols, require calculation of a shock index or use a shock index outcome as a indicator for the potential to either do RSI or not do RSI. But for those that haven't heard of it, the question really is, what is it? So obviously, for those of you that are using it, it's a rhetorical question since you can't give me feedback right now, but how are you using it in your practice? Okay. Just kind of mentioned a couple of different ways. But the real question is, why aren't you using it, or why haven't you heard of it? So what is the shock index? The shock index is basically a quick mathematical computation that allows us to have a higher than normal index of suspicion that our patient may be in hemorrhagic shock. Most importantly, it is simply the heart rate divided by the systolic blood pressure. That variable gives us the shock index, and then that number, depending on where it vets out, tells us whether or not the patient, can be, and we need to really be thinking, and suspect that the patient is in shock if they're not already manifesting overt symptoms of shock. So heart rate divided by systolic blood pressure. So you can kind of see that if you end up with a 1.0 or greater, then that is considered significant, and you need to believe your patient is in hypovolemic shock in the trauma patient until proven otherwise. Okay. So anytime the heart rate is equal to or greater than the systolic blood pressure, you're going to have an outcome of 1.0 or higher. And the literature will even go as low as a 0.9 is an indicator. I just think it's easier to remember one than a variable of a fraction of a number. So one is really kind of what we do consider and what we're seeing now as it's being utilized more in clinical practice. Okay. So that's the shock index. And this is for adults. Obviously, as you can imagine, when we get to the pediatric population, and I don't want to leave them out here because they're obviously very important, but in the pediatric population, it's a little bit more complex, if you will, because again, pediatric variations in heart rate, blood pressure, things like that. So the literature, particularly this one by Barone Capital, talked about the using the shock index for pediatrics and kind of making it age adjusted and cut off by, obviously variations in their vital signs. As you can see, as the children are smaller, as the pediatric patient is smaller, the shock index cutoff is typically higher. So again, take a snapshot of this picture. You certainly can use the reference, and this is a relatively new reference that came out in the Journal of Trauma. I believe it was probably in the late spring, maybe the early spring. But it really says really up until about the age of about 7, the shock index is going to be adjusted higher because of variations in vital signs in the pediatric population. But pretty much once you get to the age of 7 and above, you really have got more, you're using kind of the adult shock index, okay? So fortunately, most of us do not see a lot of pediatric trauma unless you're working in a pediatric center. And most of the patients that we do see that fall into that pediatric classification, and the American College of Surgeons defines it as a child, or a pediatric patient is a child or an individual less than about 15 years of age. And again, most of us are not seeing really bad trauma in 7-year-olds and less. Fortunately, then we can really kind of use for the vast majority of our patients, if not almost all of our patients, the adult shock index. But I did want to throw that in there because it really, really is important to know there's a variation with this index. All right. So look if you had not heard about the shock index before seeing this this talk up on the Trauma Geek, then you're certainly not alone. Okay. In the pre-hospital setting, we are seeing it more. In fact, when I do this talk across the spectrum and I do with the pre-hospital providers versus hospital-based providers, particularly nurses, the pre-hospital providers know about it. The paramedics almost universally now have heard of this because it's integrated, as I said earlier, into other assessments that they do from an intervention standpoint. EMTs are now starting to bustle and hear about it more and more. But nurses still, we're still a little bit behind the ball. Recently, again, at the Emergency Nurses Association, a very large meeting. It's the largest meeting of emergency nurses with over 4,000 emergency nurses. And in my particular talk, where there are hundreds of nurses in attendance, it was a smaller percentage of the nurses had heard of this and were using it in their practice. So again, it still tells me that there's a lot of work we need to do to get this out there for people to be integrating it into their daily practice. Okay. So many of you have not heard of it. Why? Well, first of all, again, if you're a nurse out there, you're probably using kind of as a standardized course in trauma is TNCC, the Trauma Nursing Core Course. And Trauma Nursing Core Course is a great course. Don't get me wrong. I've been an instructor of TNCC. I've authored chapters in it. I've reviewed it over the years. But here's the problem: TNCC doesn't mention the shock index. All right. Maybe we are now starting to in our individual courses talking about it. ENA, close your ears on this, but I certainly know that when I am teaching TNCC and I'm doing a shock lecture, I do integrate it into my lecture because it needs to be there now. But TNCC really, and we've just got the newest edition of TNCC came out, and still, yeah, it's devoid, if you will, or void in there. Okay. PHTLS, for those of us that do take or in the who practice in the pre-hospital environment and take pre-hospital trauma life support, once again, it's not mentioned there, and that's a problem. All right. TNAC. So this is one of the newer courses that's evolved out of the Emergency Nurses Association, the Trauma Nursing Advanced course. Round of applause on that. Yes, TNAC does cover the shock index, and it is pretty decently discussed. So I'm very thrilled about that. But again, here's the key: trauma nursing advanced course. How many people have taken TNAC at this point in time? Very, very, very few. I mean, maybe a couple of dozen, maybe 3 or 4 dozen nurses universally have taken TNAC at this point because it is still relatively new. And then last but not least, I'm sorry about that. Last but not least, ATLS. Well, the new edition of ATLS is ATLS 11, which is launching even as we speak, does finally talk about the shock index. In previous versions of ATLS, particularly the 10th edition, which is the edition we're transitioning out of right now, it mentions it in the book, but it gives no basis for it. And it's really not covered at all in any of the interactive case studies. So there is really a devoid of it being out there. And that's bad on the part of the professional organizations that are putting these courses together, and then those of us that are out there teaching trauma and teaching shock and trauma, that we're not talking about it. But not with me. Trauma Geek is out there, and you can be assured if I'm talking trauma with you, you're hearing it. Here's the other thing: if you go to meetings, if you go to any of the talks, if you go to conferences, and if you're reading the literature outside of these standardized courses, you are most assuredly seeing the shock index or hearing about the shock index. Okay. What brought it to my attention was this article that was published in Trauma Surgery and Acute Care Open. This is a British medical journal, online journal that's free and open access to everybody. And this was a article that was published in 2021, so about 4 years ago. And it goes to show you how relatively new it was for me. So about 4 years ago, I came across this article. I used it as a basis for my trauma nursing journal club. And this really struck me. I saw this article, I looked at it, I read it, and I like, wow, why didn't I know about what the shock index was? And why haven't I been using it in my practice? And look at, very rarely does one article change the way you look at things, and or one talk, like we're doing today, changes your way of doing things. But this one did. It absolutely changed the way I think, and it has changed the way I think and practice and integrate this particular calculation into my care of any patient that's trauma or not traumatized. There are two things that I do. There's a number of things I do on every patient that I put my hands on, but one is I get a Glasgow Coma score, and one is I get shock index now. Okay. So this was brought to my attention, and you know what? You still got to wonder. As I saw this article, I'm thinking, why haven't I seen this before? Right? Well, we talked about TNCC, PHTLS, ATLS at that time, and this was going back 4 years ago. Wasn't mentioned. TNAC was still, I think, still a theoretical course in ENA's eyes. It also wasn't used in the old trauma triage guidelines that we used to use, the CDC ones that came out, I think, in 2011. So it wasn't there. Right. We all know that those guidelines were kind of in the field where the initial triage served as our basis, but the initial trauma triage is the basis for a number of things. Well, first of all, we use the pre-hospital trauma triage guidelines, or the field triage guidelines as they're known now, for pre-hospital trauma triage, and then for level resourcing in trauma centers on patient arrival, right? The other thing is that when we looked at the old trauma triage guidelines, I'm only going to put these up there quickly because they're old, the main parameters by which they were looking at things, and it still doesn't deviate too much from there now, is they looked at physiology, they looked at anatomy, and they looked at mechanism of injury. And in physiology, what they looked at is the good old standby, the gold standard, which was systolic blood pressure. And they basically said a systolic blood pressure of less than 90, all right, was indicative of shock. All right. Well, was it? Was it not? I don't know. I think any of us that have been practicing for any more than probably a few months know that a blood pressure alone, a systolic blood pressure alone, should not be a sole indicator by which we look at things. But it was. And we looked at it in concert with other things. We looked at it as respiratory rate, because we know if somebody's increasing their respiratory rate, they're probably blowing off carbon dioxide or acid, so maybe they're acidotic. But the reality is that it was a very, very, very narrow parameter which we were using. Okay. Then came the national guidelines for the field triage. This came out through the American College of Surgeons. It was a it was a good change from the old guidelines that we saw. And what we saw here, again, for the adult patients, is they integrated the heart rate greater than systolic blood pressure. They don't overtly call it the shock index, but that's exactly what it is. So if the heart rate is greater than systolic blood pressure, or it really should be equal to or greater, actually, but it's not listed that way. It's going to give you that one, and in the adult trauma patient or the patient greater than about 7 years of age, it's going to give you a higher than normal index of suspicion that there could be hemorrhagic shock going on. Okay. Now, shock index isn't new, right? We can go back in the literature and find it first being referenced in the German medical literature in 1967. 1967. So almost 60 years ago, right? For 58 years ago. Basically, Algauer and Murray discussed what they called the shock index, and the shock index was measured in the critical care setting in the ICU, and it was done using arterial blood pressure and pulse at that time. But look, that's some of the earliest articles that are out there on the shock index. And guess what? Here we are, 2025. And for many of you, this is the first time you're hearing about it. So again, we definitely are way past due at getting that out there. Okay. Now look, it's out there. Now this is as of August 25th. So this is actually at the time I had to get these slides into ENA as their cutoff. I've actually looked it up since then. PubMed at that time, there was about articles published, almost 18,000 articles. We're actually over 18,000 articles now, about a month later, okay? And then when you look at Google searches for the parameter of shock index, there were over 8 million searches. So clearly people are hearing about it. Clearly the literature is abundant with references on the shock index, and clearly people are looking it up and trying to reference it out. So it's out there, right? Now, the shock index, as we're talking about it today, in this very short 30-minute span of time that I had for this presentation, is focused on trauma. The reality is it can be used across the board for like almost any hemorrhagic related incident. So it could be used for GI bleeds. It could be used for postpartum hemorrhage. It can be used for ectopic pregnancy. It can certainly be used as shock for things like sepsis and MI, cardiogenic shock. It has some applications, although I haven't explored them for stroke. Obviously, sepsis, you can imagine, and then the pediatric applications that we've kind of already talked about. So it's across the gamut. There's, almost a baker's dozen, if you will, of different options that could be available out there outside of trauma. But we're focusing on trauma today. All right. And there's some variations of the shock index as well, okay? The shock index can certainly be looked at in a variety of different things, and they've studied it. And what they have done is they've come up with some complicating factors here, and some of these do get a little bit complex, as you can see. But the reality is across the board is they have found that regardless of how the shock index is reformulated and applied, the same thing holds true, is it obviously is a decent indicator of potential for shock, potential for the need for some level of a transfusion, either in the pre-hospital environment, in the trauma bay, all right, high index of suspicion for need of operative intervention, and then ultimately critical care and okay? So these are pretty sick patients when they come in, all right? Again, another interesting article, this was out in 2023. Rapucci et al. Talked again about what they call the reverse shock index multiplied by the Glasgow Coma score. In this particular study, which was a decent study, it showed that in the pediatric population, this particular formula that had statistically significant findings of predictability for increased need for intubation, increased need for intracranial pressure monitoring on TBI patients, the need for blood product transfusion, either whole blood or component therapy, need for operative intervention, and again, the need for ICU admission. Very similar to what we see in the adult literature. We saw the same thing in the pediatric literature. Okay. So the gold standard really, why is it no longer acceptable? Well, first of all, we have a lot of data now in the literature on the use of the shock index. But what really was the problem with using a systolic blood pressure of less than 90? All right. Well, there you go. There's a litany of them. First of all, it's an arbitrarily selected number. There's really no evidence in the literature to support why 90 was chosen. All right. And here's another variable. A lot of people have a normal systolic blood pressure that hovers around 90. All right. Blood pressure, no ranges change between groups. And we can have hypotension due to a number of other causes, not just, what we're doing, not just with what we think about. So again, When you look at the base of literature there, it's not there. The other thing is that we all have our own peculiar ways of obtaining blood pressures, right? A lot of us use auto cuffs exclusively, which is the work of the devil, in my opinion. When it comes to manual cuffs and even auto cuffs, it's placement of the cuffs, it's the size of the cuff, is it sized correctly? And there's clinician variability. How many of us have worked with a clinician that every blood pressure they get is 120 over 80? Or 118 over 72, or yeah, normal, right? And you know what? There's no consideration whatsoever of heart rate in there, huh? You know, WTF on that? I mean, heart rate is a central vital sign. Heart rate is very, 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 very reliable when it comes to looking at trending. And when you take that and now combine it with a systolic blood pressure, again, the literature is showing that we do have something that is a pretty reliable index for suspicion. All right. So let's go back to this article very, very quickly, because again, this is really what turned my opinion on this. Again, this is available. It's by Kierback. Again, if you want to take a screenshot of this, I urge you to do so. It's also on my reference list. You're watching it on video, so you do have the fortune of coming back and looking at this, but absolutely look at it. You can download this article free of charge. And it really, really, like I said, for me, it was a practice changer for me. All right. It was kind of interesting because basically what they did in this particular study is they compared hypotension as a sole indicator of significant injury versus patients that were normotensive. They had a patient pool of about 544, okay? So roughly 82 people were hypotensive, 460 patients were normotensive, all right? 66% of the patients in their study, so 66% of the 544 had significant injury without ever displaying hypotension, okay? Defined hypotension, blood pressure less than 90, all right? Of those that survived, okay, survivors of the emergency department, hypotension is an independent factor, was not associated with increased need necessarily for operative emergent intervention or increased mortality. All right. But the significance here is that hypotension was really a poor indicator of serious injury. And the boxes that I have blocked off here kind of show you. And the p-values, even though some of the p-values were not significant, when you look at some of the numbers in there and the percentage differences, they do make you go, huh, and what's going on here? And particularly when we look at injury, when we look at the need for blood products, when we look at the need for emergent operations, and then again, overall in-hospital mortality. We're not impressed with hypotension by itself, but guess what? If we then took and made a comparison with the shock index, so now we took that same group of people and we looked at the shock index in them, and obviously we needed to make sure they had both a heart rate and a systolic blood pressure recorded. We saw across the board very big differences. All right. So those with the shock index of greater than 1 or 1 or above versus those that were less than 1. We see across the board some very significant findings there. And those significant findings really all lead to the fact that a lot of these patients, it was predictive of a high index of suspicion for serious injury, a high index of suspicion for needing fluid resuscitation, blood resuscitation within 24 hours, if not in the trauma bay or in the pre-hospital setting. It was somewhat predictive of death in the emergency department and the need for operative intervention. So we see this. And again, a lot of the studies have replicated this out and found really these 4 things do continue to hold true even to today. Again, then some more statistics and looking at some of the other kind of shock index as it was outperforming hypotension. It's boring stuff. It's got the great p-value of certainly almost as low a p-value as you can get, which again tells you there is some clinically significant findings that are here, that the shock index should, if not absolutely should, be looked at as a lot more of a reliable indicator than the old gold standard, which is systolic blood pressure alone. When again we look at the literature, just kind of to summarize this up, we see that hypotension alone typically is not a reliable predictor of those 4 variables that we really look at when it comes to how bad people are injured. The significance of their injury, or do they need some level of resuscitation, which means they're probably in some level of hemorrhagic shock, Do they need operative intervention, which means in addition to maybe getting blood, we're not stopping the bleed, so now we need to take them up and do some of that surgery mojo? And are they likely to die either in the emergency department or maybe down the road if we don't treat them appropriately? And we did find that the shock index, particularly that was equal to or greater than 1, was certainly a more predictive variable than the old gold standard of systolic blood pressure alone. All right. And then again, the literature has kind of been showing more and more now that we look at it a little bit more critically that we need to be relying on more than one variable when it comes to looking at to see how bad a patient may or may not be injured or maybe encroaching on hemorrhagic shock, right? Again, not to beat this like a dead horse, but I will, that systolic blood pressure alone, we shouldn't be going for it anymore. It's an arbitrary number. It's not always applicable in a certain segment of our population, adult population, who may be athletic or maybe small in body habitus, who may normally have a blood pressure that hovers around the 90s to the mid 90s, okay? And there's always a lot of confounding variables that are going to be interfering with vital signs in general. And we always want to make sure that we always keep that in mind as well. All right. Comorbidities absolutely are going to be there. Polypharmacy, yes. What are they on? Particularly, we know in our environment, if they're on things like the beta blockers, the calcium channel blockers, and the anticoagulants, that our flags go up to be looking at these blood pressures and their heart rate a little bit more microscopically. And the age of the patient, obviously the very young, we look at things a little bit different in our pediatric population. There's not a lot of literature on the older adult, and I'm going to define older adult for the purposes of my talk as adults greater than 75. Sorry, those were not gunshot wounds you just heard in the background. It was a backfiring vehicle. I think nobody laying on the street. So that being said, because of the confounding variables, and particularly for the elderly patient population, I still do believe this holds true. I do believe in my practice that I've seen it, but do bear in mind that, again, that surrogate marker of hypotension in the elderly population, all right, and again, that's greater than 65, is 110 systolic, not 90 systolic. So, be thinking about that. But again, if you've got somebody who's on a beta blocker and they've got a heart rate of 100, they've got a systolic blood pressure of 108, and they're on a beta blocker, they may never mount enough of a tachycardic response to be able to reliably use a shock index in that. So be thinking about that. The other thing that I think is important is the American College of Surgeons is certainly using the shock index more now. Okay. We're using it in the pre-hospital field triage guidelines. It's now integrated in ATLS 11. And then we're seeing again being utilized across the board. ENA has now come on board as integrated into TNAC. And I think eventually NAEMT, who runs the PHTLS program and the TECC program, we are certainly going to be seeing that integrated moving forward with new additions coming out there. PHTLS has got a relatively new edition that just came out. TECC is coming out with a new edition probably in 2026, I'm going to guess. I was part of the committee working on that. So, and I'm pretty sure we're going to see shock index integrated there, okay? And again, it's listed up here again. It's in the 2021 guidelines, which again are now 4 years old. It's incorporated into a lot of trauma centers, trauma team activation protocols. In my shop in Patterson, we absolutely use the shock index as an indicator for our higher level of trauma team activation. It's certainly integrated into talks like this and articles discussing it. And trauma clinicians should be using the shock index in their practice. So the real question is, are you? And hopefully, after hearing what you've seen today, you've at least your curiosity is piqued. I don't expect you to go out and start doing this tomorrow. If you do, thank you very much. But if you don't, that's okay. Don't discount it. Go out and look at the literature. We should all be guiding our practices based on best available evidence. And the literature does abound now with good literature with regards to the shock index. Okay. Okay. So from an emergency nursing standpoint, because obviously this is emergency nursing centric, a pre-hospital provider standpoint, if you're not integrating this into your daily practice, you probably should come up with a good rationale as to why you're not. Okay. So I do appreciate all of you tuning in today. It was a relatively short talk, but there's my contact information up there. If you want to email me, you want to leave a message on YouTube, that is great. And I think at the end of the day, what I'd like to see is that hopefully this talk has resulted in you at least thinking about changing your practice and wanting to investigate the shock index a little bit more. So again, appreciate you for tuning in today. Take care, and I'll see you in the trauma bay.